All right. Looks like a bunch more have hopped on, so we will get started with this presentation on the changing landscape of wellness vaccine in adults. We are so happy to see so many of you were able to hop on right before the holiday season. My name is Mary Lizakowski, and I'm a Coalition Health Director with the Foundation for Healthy North Dakota, which is a nonprofit organization established in 2022 with the mission to promote health and wellness across North Dakota by working at the community level. We are continuing to expand our statewide coalition to foster collaboration among local communities on common initiatives. And by becoming a member of the coalition, you will be the first to receive information about educational opportunities like this one and updates on relevant public health information, legislative news, as well as access to digital advocacy resources and toolkits. Just a couple housekeeping things to cover. Webinar attendees will be automatically muted for the presentation. If you have questions, please put them in the chat box and we will be monitoring that. We are recording this presentation and will reserve time at the end to answer any questions. And after the presentation, a link to the recording will be sent out along with an evaluation survey. It is my pleasure to introduce our presenter today, Dr. Keipp Talbot, who is a professor of medicine and health policy within the Division of Infectious Diseases at Vanderbilt University Medical Center. As a dual appointee in medicine and health policy, Dr. Talbot has played a pivotal role in the evaluation of viral respiratory diseases in adults and the evaluation of new and existing vaccines in older adults to improve immunization policy and vaccine development. Her goal is to continue to evaluate the use and effectiveness of vaccines with a focus on prevention of infection and morbidity in adults. Dr. Talbot began her career by investigating the presence of influenza in hospitalized adults. Her recent work has contributed to our understanding of the epidemiology of SARS-CoV-2, influenza, and respiratory syncytial virus. Dr. Talbot is currently the chair of the Advisory Committee on Immunization Practices and has served as the chair of the ACIP's Influenza Vaccine Work Group and co-chair of the COVID-19 Vaccine Safety Technical Work Group. She has authored more than 260 manuscripts. Her work has informed national policy on the implementation of enhanced influenza vaccines for older adults, the use of pneumococcal vaccines in the setting of changing epidemiology, and COVID-19 vaccine introduction and use. Dr. Talbot currently co-leads the Tennessee Emerging Infections Program at Vanderbilt, which works to better understand viral respiratory disease epidemiology and inform vaccine policy. So it's my pleasure to welcome you today, Dr. Talbot, and I will turn it over to you for your presentation.
Hi, it's so nice to actually be here during the holidays and talk to everyone. This is one of my favorite topics. It's a little bit different than usual vaccine talk. Usually we talk about children, but we're going to change the playbook. And I'm going to see if I can share slides. I'm also going to warn you that my dogs would like to contribute to this meeting. So bear with the background noise. All right. So as I mentioned, we're going to be talking about adult vaccines. All right, so the obligatory slide, I receive funding from the CDC to do research, but that being said, this does not represent the CDC or the Advisory Committee on Immunization Practices. This is one of my favorite things I've ever seen, and unfortunately, I have no idea who originally wrote it. It says, I got vaccinated as a kid. As a result, I am now starting to gray and bald. My balding got so bad I had to shave my head. I've also gained weight. Because of vaccines, I have started aging instead of dying as a baby. And this truly highlights the success of the vaccine program that we have had for children. It really talks about how our children who previously would have died due to vaccine preventable illness have now become adults. But as we age, also comes the complications of different diseases. So this talks about herpes zoster, most commonly known as shingles, and that's in that kind of light blue. And the rate of shingles increases as we age, remarkably as we age. The darker blue is what we call postherpetic neuralgia, and that's actually a complication of shingles, which is associated with a great amount of pain and can last years and can be incredibly difficult to treat. So shingles increases with age. I actually cannot see the top of my slide because of the thing. I believe this is new. Oh, it's hepatitis. Sorry. So the hepatitis, if you look, this is done by age. Those over 60 have lower rates, but those that are 30 to 39 and 40 to 49 have higher rates of hepatitis B. So this is an adult illness. This is invasive pneumococcal disease. So pneumococcus is most known for causing pneumonia, but can also cause meningitis. It can cause endocarditis, and it can also cause bacteremia and sepsis. So what you notice here is that those over 65 years of age, those in the dark blue, have the highest rates of disease. You'll also notice this has fallen over time. And we'll come back and talk about that. These are COVID hospitalizations by age groups. Over 65, far and away, has the highest rates of hospitalization. These are respiratory syncytial virus. Now, the 0 to 4 is the purple, and those are children. By far and away, the highest number of RSV hospitalization is in children. But if you look right below that, or actually further down, the light blue is adults over 65 years of age. So after children, adults over 65 years of age have the highest rates of hospitalizations due to respiratory syncytial virus. And it actually increases as the age continues over 65 years. We're going to talk a little bit about the silver tsunami. Our population in the US and actually in the world is aging. This is what's anticipated for the US population over the next 75 years, where we'll see adults over 65 years of age increase and actually be higher than kids 15 to 24 and children 0 to 14. And what this looks like, these are the population pyramids that have been shown in the past. In 1960, the pyramid on the left, you see that the most populated part of the US population were children less than 10 or 15. And that continued to decline as age went on. And there are very few people over 80. Looking now in 2024, there's just as many older adults as there are children. So there's in the 70 and above group is just as wide almost as the children. And you notice the children less than 5 is smaller. So we're seeing a much older population than we have in the past. And we notice that these diseases that we've mentioned can affect all adults, but the most severe disease, the greatest burden, and the highest hospitalization, for the most part, are in older adults. And there are a lot of reasons why we see this increase in older adults. One is malnutrition. As many older adults lose mobility and lose the ability to drive, they may or may not have the access to food. Comorbidities, I'll show you how we have an increasing number of comorbidities as we age. We'll talk a little bit about polypharmacy and anatomic changes in immune senescence. So this graph shows the number of comorbid conditions or the number of medical problems that we have as adults over time. This is an average, not every 85-year-old has greater than 8 disorders. But what you see as we increase in age, the blue gets darker and darker, indicating higher numbers of health problems. And as we accumulate health problems, infections can actually exacerbate them. So if you have influenza, and you have heart failure, you can actually have a worsening episode of heart failure or even a heart attack once you get influenza. Polypharmacy is common, so we use a lot of antibiotics in this country, appropriately sometimes and sometimes inappropriately. But when we use broad spectrum antibiotics, we can actually change the normal bacterial flora of our body, which can put us at risk for infections. We also use a lot of corticosteroids. So, steroids can suppress the immune system and increase the likelihood that we get infected. Older adults get exposed to a lot of corticosteroids, whether that's for treatment of an acute emphysema exacerbation or whether it's for arthritis or other reasons. There's a lot of steroid use. And believe it or not, opioids used for pain management can actually increase the risk of pneumonia. This is a very complicated slide. Please don't memorize it. This is just looking at the anatomic changes that occur with aging. And some of the big ones, especially the lungs, there's reduced cough strength, there's reduced ability of the cilia lining. And the cilia is this little hair covering in our lungs and our bronchus and our nose that kind of kicks bacteria and viruses out. And so if they're not as mobile, it's harder for them to decrease this out. There's also decreased movement of the lungs to opening it up. And similar changes occur in all parts of the body with aging. I'm going to talk a little bit about waning immunity. It has lots of names, including immune senescence, inflammaging, and some of these changes are adaptive versus maladaptive. So this is immune senescence. This is a snapshot of an older immune system. Once again, please don't memorize this. But you'll notice there's a fair amount of inflammation, hence the nickname inflammaging. And some of the cells are upregulated, which is that dark black line, and some of them are downregulated or attenuated with age, and those are those dotted lines. So it's a little bit of a dysregulation that occurs. Your normal immune system are the white and the orange here. The abnormal is the pink and the red. So when we acutely become ill, we release interferons called IL-6 and a C-reactive protein, CRP. And what should happen is that you get exposed to some illness, you quickly turn on your IL-6, your CRP, you deal with the pathogen, and then they return to normal. But what we see in older dysregulated chronic inflammation is that it really takes a long time for that IL-6 and CRP to get moving. And when they do, they don't turn themselves off. So they really aren't responsive to the pathogen. I have 2 kids, they're older now, but I call this the screaming kid phenomenon. If your kids scream all day long, you learn to tune them out so that you can do what you need to do. And when your kid finally hurts themselves and is screaming, you miss it because they've been screaming all day and you've tuned it out. We've all done it as parents. All right, so there are consequences of this immune senescence, and this explains why we see such a high burden of infections in older adults. We see an increase of susceptibility to infection. We see it takes them much longer to recover post-infection. Unfortunately, the same susceptibility to infection also means a poor response to immunization. So it's a double-edged sword. They're the ones we want to use vaccines in because they're most likely to get infected, but the vaccines are less likely to work. We also see increased neoplastic and autoimmune, so increased cancer and autoimmune disorders. All right, so how different are these responses? So this is a graph that looks at seroconversion. In other words, how much of the population increases their antibody response by fourfold. You see young and elderly, and we look at each type of B. So for H1N1, the elderly have lower rates of seroconversion. H3N2 is the same, and B is also the same. And so what does that mean? It means that the vaccine effectiveness is lower in older adults. So the dark color is adults less than 65, and then the lighter gray color is adults over 65. Vaccine effectiveness, how well the vaccine works, is on the left on the Y column. And then on the bottom, you'll notice the years. So almost every single year, older adults have lower vaccine effectiveness than younger adults. And just to make this much more complicated, this is not just about age. We all know that 80-year-old that does the Senior Olympics and plays tennis every day, and they're doing great. They take few medicines. And then we know 60-year-olds who are really struggling. They're having problems with mobility. They have lots of comorbid condition, and they're on lots of medications. So as Indiana Jones says, it's not the years, honey, it's the mileage. So we try to measure that with a concept called frailty. So frailty is basically a lack of reserve. We see this in patients and family members. We know if they get pneumonia, they're just not going to do well. And it really kind of starts with weakness, slow walking speed, lower levels of physical activity, fatigue and exhaustion, unintentional weight loss. And you can also see the changes in mobility that occur. So if we looked at frailty and influenza, we can look at how well frail individuals respond to influenza vaccination compared to those that are not frail. So this looks at each of the flu types, H1, H3, and B. And what this looks like is how well you respond pre and post-vaccination, or post-vaccination compared to pre. The first column is everybody. The second are those that are not frail, then pre-frail, so they're getting up frail, and then the frail group. And for each of the influenza types, the frail older adults have a decreased response to influenza compared to similar aged non-frail adults. And once again, what does that look like? Well, who gets influenza? It's unfortunately the frail individuals. And it also impacts immune response and other viruses. So it's not just influenza. This is for COVID. And the left graph is the spike protein, and the right graph is the receptor binding domain, which is part of the spike protein. It's just a very particular part. Blue are those that are mild, purple are moderate, and red is severe frailty. So these were a group of adults that were given vaccine. And at 2 weeks, the most frail, the severe frail, had lower responses. 6 months post-dose 2, they had lower responses. However, if you give them a third dose, those people who were severe come up and match the mild and moderate adults. So really, we can overcome the antibody response if we give more vaccines for COVID. And the same thing was seen in the receptor binding domain. If we look at COVID vaccine effectiveness, same thing, black is frail, yellow is robust. We see decreasing vaccine effectiveness based on frailty. So why do we use vaccines? Since I showed that there's lower effectiveness, well, I want to point out it actually showed some effectiveness, and that's incredibly important. But one of the most important things that vaccines do in adults is not prevent illness, but prevent complications of illness. So if you get influenza, which is possible, I don't want you going to the hospital. I don't want you having a stroke, a heart attack, or heart failure. I don't want you in bed for 7 days and you lose your mobility. I don't want you to fall and break your hip. So we use vaccines in older adults, not necessarily to prevent infection, but to prevent complications. This is very different than what we do in children. If we give a measles vaccine, they don't get measles. It's remarkably effective. So it's very hard for a lot of adults to say, well, I still got sick. Well, yeah, you might still get sick, but you didn't go to the hospital or you didn't have a stroke. Those are the things that we don't communicate well to patients about why we use these vaccines. So how do we make this better? How do we improve? How do we keep adults safer than what we're currently doing? Well, there's several strategies. One is, what if we vaccinated them when they were younger, when their immune system was still intact? There's been no research on this, but it's a really interesting concept. We're going to talk about herd immunity or protection. There's some really interesting data on pneumococcus in children, which I'll show you, and healthcare workers and influenza. We'll also talk about, well, could we give the immune system a little nudge? Could we improve the immune response? And there's some ways that we can do that that we'll talk about. And there's actually new vaccine technologies coming along, which is very exciting. All right. So we're going to talk about herd immunity or protection. And what that means is we protect those that are vulnerable in a population by immunizing those that are less vulnerable. So this is the slide I showed you earlier about invasive pneumococcal disease. Once again, just to orient you, these are cases per 100,000 population. The dark blue is adults over 65, and that kind of gray color is children less than 5 years of age. In 2010, we introduced the pneumococcal conjugate vaccine in children. It was incredibly exciting to introduce this vaccine. If you notice that gray line falls off precipitously, means that vaccine reduced children in a remarkable amount. Now, this only applied to the pneumococcal types that are in the vaccine, but of those pneumococcal vaccine types, it fell. What we did not expect is that dark blue line to fall. So after 2010, the disease in adults over 65 dropped. Why did this happen? Well, it turns out children can carry pneumococcus in their nose and throat. And when they visit their grandparents and love on them, they somehow manage to share their pneumococcus. And so actually January 1st every year, we would see these huge spikes of pneumococcus. Be Christmas, all the grandkids would be around, the runny nose, the big hugs, the not washing hands, and older adults would actually catch the pneumococcus from the children. When we introduced the conjugate vaccine in children, they no longer carried pneumococcus in their throats, at least these 13 kinds. And when that happens, they became unable to spread those types of pneumococcus to older adults. So when we vaccinated the children, we had a huge impact on the adults. In around 2015, we introduced pneumococcal 13 in adults, but you can see there wasn't really much of a further drop. The biggest bang for the buck with this expensive vaccine was vaccinating the children. Just for curiosity or interest sake, when COVID-19 hit in 2020 and everyone sequestered and stayed home, pneumococcus dropped a lot. And as we came out of that time of staying home and not doing things, pneumococcus has gone back up. All right, I'm going to talk about nursing homes and healthcare workers and influenza. This is a busy slide. This talks about patient mortality. So this is the patients who live in the nursing home, what their mortality is. So there have been several randomized controlled trials that have looked at the impact of vaccinating the healthcare worker. So the first study was done published in 1997, and they look at 7 long-term care facilities in each arm. So one arm, they went in and said, hey, we'll vaccinate the healthcare workers. Here's the flu vaccine. And whoever wanted it could get it. The blue arm was the facilities where the healthcare workers were not vaccinated. Now, some of these healthcare workers may have gotten their vaccine from their private primary care doctor, but the nursing home did not bring vaccine in to vaccinate the healthcare workers. And what we see is there was a huge reduction in mortality, that blue line, in the patients when the healthcare workers were offered vaccine. They were told the study was too small, so the study was repeated with 10 nursing homes in each arm, and then 22 nursing homes in each arm. It was done a fourth time. Unfortunately, there was very little flu that season, and they couldn't show a difference. But in 3 of the 4 with normal influenza seasons, we see a remarkable decrease in patient mortality if healthcare workers are vaccinated. And just so you know, these studies did not show an impact of vaccinating the actual residents. So the biggest bang for the buck was actually vaccinating the healthcare workers who worked in the nursing homes that would go out into the world, be exposed to influenza, and then bring it into the nursing home. We're going to talk about adjuvants. These are a new thing. I'll talk briefly about some of the newer ones that have been added, but it was totally serendipitous. So we used to vaccinate horses to get antibodies to treat things like pertussis. And what they found is that they rubbed dirt at the site of the injection. They had better antibody responses, especially if an abscess was formed. Now, we don't rub dirt when we vaccinate people now, but we have found some compounds that create a similar response. And there's lots of them. There's aluminum salts, which is common. There's emulsions like ASO3 and MF59, which are used in adult vaccines. There's some microparticles that are coming along. There's ones that stimulate certain part of the immune system called toll-like receptors. And those are receptors that recognize foreign things immediately. We can combine adjuvants. We can use adjuvants that work on the mucosa, so the mouth, the nose. And there are lots of vaccines that already have these. So these are the aluminum hydroxide ones. These are some of the newer ones. So ASO4 is in hepatitis B. MF59 is in the adjuvanted influenza vaccine. CpG 1018 is used in hepatitis B. AS01B is in the recombinant shingles vaccine. And the adjuvanted RSV vaccine, there are 2 RSV vaccines, uses ASO1E. So this just shows that we have been able to introduce these adjuvants into vaccines. So when we use the vaccines in older adults, we get more of a kick of the immune system and better immune responses. There's some new technologies coming. Messenger RNA was the most recent one, and that actually showed incredible responsiveness with the immune system. DNA has been used. We had it briefly in this country, but didn't stay. It was the Johnson & Johnson vaccine. Recombinant subunits are an idea where we take a small portion of the bacteria or virus and grow it up in huge quantities. And then there's some nanoparticle ones like the herpes, like the human papillomavirus. All right, so I'm going to talk a little bit about vaccines for the aging immune system. So these are vaccines we use in older adults. That being said, we still use vaccines in younger adults, but these are the ones that have been developed and we recommend in older adults. And if you notice me bouncing up and down, it's because I actually do get very excited about this. This field has changed dramatically. This is shingles, and was one of the first vaccines that was expressly developed for older adults. So the childhood chickenpox vaccine was developed and was highly successful. And so the idea was, what if we increase the dose? Because older adults have already had chickenpox. If we increase the dose, what will happen? And so what they found, the black is placebo, and then gray is the live zoster vaccine in high doses. That if you gave this vaccine, you significantly reduced the incidence of herpes zoster. So it was 50% in all subjects. It was most effective in those 60 to 69. Less effective, but still effective in adults over 70 years of age. So basically, overall, it halved the incidence of shingles. But most impressively is the prevention of the post-herpetic neuralgia. So that's the pain syndrome that can follow shingles, difficult to treat, and can be prolonged. So 2/3 of the patients who had shingles did not get post-herpetic neuralgia. It's incredibly impressive. This vaccine was a live attenuated, which means it couldn't be used in anyone who was immunocompromised, and was really good, but could we do better? And so this is the adjuvanted herpes zoster vaccine. So I mentioned it on the earlier slides when we talked about adjuvants. And this is off the chart amazing. For the prevention of shingles in those that are 70 and older, they had a 98% efficacy. So almost 100%. Unbelievable. And we just don't see that for most adult vaccines. And this is also the reason why if you get a shingle shot, your arm hurts and you feel pretty bad. It's got a kick to it, but is incredibly effective. And you can imagine if we prevent shingles, we prevent post-herpetic neuralgia. All right, so we're going to talk about influenza. Interestingly, the influenza vaccine was developed in Army recruits and college students after World War I. So the Army, primarily in World War II, the Army was very worried about losing people to influenza because in World War I, we lost more men to influenza than we did to war. So the vaccine was developed in this young population. It was in 1960 that we actually in the US said, hey, this vaccine works in young adults. It should at least work in older adults, right? Or at least partially. And so we have used the influenza vaccine without a good randomized controlled trial. They were right. It did work, but not quite as well as we would like. So one of the first steps was say, hey, what if we increase the dose of the influenza vaccine? So we usually put 15 micrograms of each influenza type in a vaccine. And they looked at the response in the participants, like how many actually had a good antibody response if they increased the dose. And what you see is 0, so not a big response. At 15 micrograms, the normal, 30, which is higher, and 60, which was the highest they tried. And what you see is you kind of get a leveling off at 60. So the idea was, well, what if we give an influenza vaccine that's 4 times the dose? And that's what they did. Sorry, went too fast. And what they found is if you use the higher dose, the vaccine was 24% more effective than the standard dose. So still not a home run, but definitely an improvement over the standard influenza vaccine. I mentioned the MF59 vaccine. This is an adjuvanted influenza vaccine. So it is the standard dose, but with an adjuvant in it. This vaccine has been used in Europe for many years. And it was introduced to the United States about 10 years ago and has been shown to be better than just a standard influenza vaccine. Oops. All right, so we're going to talk about pneumococcus. So pneumococcus is a huge cause of pneumonia, but as I mentioned, also causes meningitis, bacteremia. Sorry, my daughter's leaving for to visit cousins. And endocarditis, infection of the heart. And these bacteria are really interesting. There's the bacteria, and then it sends out these sugars, which we call polysaccharides, and they spread around the whole bacteria. There are lots of different types of polysaccharides. So there are about 100 different types of pneumococcus based on the polysaccharides or the sugars. And I mentioned earlier about the 13-valent conjugate vaccine that had 13 different types of pneumococcus in it. The polysaccharide itself is not a good stimulant of the immune system. So for years, we did not use pneumococcal vaccines in kids because sugars just don't stimulate the immune system. But what was found out is if you hook that sugar to a protein, like a diphtheria protein, the body recognizes it as foreign and creates an immune response, hence the development of the pneumococcal conjugate vaccines called PCV. And they have been highly successful, as I showed you earlier. Now, these vaccines are being increased. So if you notice, there's a pneumococcal conjugate vaccine 15. There's a pneumococcal conjugate 20. There's the old polysaccharide vaccine 23, which doesn't stimulate the immune system as well. And then actually, there's the pneumococcal conjugate vaccine 21. So each of these covers most of the same pneumococcal type, which is on the top 1, 3, 4, 5. We're not very descriptive. We use numbers. Sometimes we add letters like 6A, 6B. But the 21 is a different one in that it said, hey, look, the kids have done such a good job of preventing disease in adults that the disease in adults are different than the types of pneumococcus in children. And so the 21 has changed and used different types of pneumococcus to try to better get at what the adults get. And so this shows you, once again, the rates of pneumococcus, but this shows you by type of vaccine. So not that the vaccine causes this, but this is what could have been prevented if the vaccine was used. There's still a lot of disease in those 19 to 49 years of age. This is due to health problems like diabetes, no spleen, immune suppression, sickle cell anemia. But when you look at those 50 to 64, there's a lot of disease. And a lot of it could be prevented by using either PCV 20 and 21. And this shows very similarly what happened in adults over 65, just once again, because it's so impressive, that when PCV 13 was introduced, the disease went down in adults over 65. And hopefully, as we continue to introduce newer vaccines with more polysaccharide antigen in them, will prevent more disease. All right, so we'll skip that. There's some major differences in children and adult immunization. Children vaccines or immunizations have a schedule that's age-based. It makes it very easy. Their visits are scheduled around their immunizations. Either vaccines are paid for through private insurance or for the VFC, which is vaccines for children. So all vaccines are paid for regardless and can be given in the pediatrician's office. And mostly, in most states, there's a comprehensive state registry. For adults, however, the recommendations are risk-based, which means if you have this disease, you get this vaccine. If you have that disease, you get a different vaccine. And it can be incredibly complicated and time-consuming when in clinic. Adults have lots of complex medical issues, so they may come in with 10 health problems and vaccines get put on the back burner. There's no full coverage for adult immunizations. So vaccines for adults, or VFA as we like to say, does not exist. I mentioned that all vaccines can be given in the pediatrician's office. That's not necessarily true for adults over 65. Some vaccines are Medicare Part B, which means you can get care for that within the doctor's office. These include pneumonia, pneumococcus, influenza, and COVID. However, all other adult immunizations, hepatitis B, there's some exceptions, but all other adult vaccinations are covered under Medicare Part D, which is the pharmacy benefit. So to have it paid for by Medicare, you must receive it in a pharmacy, which means I've had a conversation with my patient about the RSV vaccine, and then they have to go to the pharmacy to get it. And you can imagine they can change their mind in the meantime, they can have questions in the meantime, or they can just forget about it. We also, in most states, have very poor documentation of adult immunizations. So most adults do not remember when they got their pneumococcal vaccine, and it's difficult to find in healthcare records. Now, a lot of this has changed with the introduction of the COVID vaccine. It was required for states to document COVID vaccines if they give COVID vaccines. And so many of the pharmacies, healthcare providers, health networks started putting information into state immunization registries. And luckily, that practice has spilled over to other vaccines, but is not quite 100% yet. All right, so some conclusion is our older population is growing. We need to understand how vaccinating other populations might help our older adults. Our older adults have dysregulation of the immune system, and it's not solely predicted by age or comorbid conditions. We need more immunogenic vaccines, and we need to understand what vaccines are preventing. So when we talk to our patients, we don't go, oh, you won't get the flu this year, when we know you might, but hopefully you don't get hospitalized or have a heart attack. Just a little bit of humbling. This is the world records in time for marathon for men. And the fastest time is men over 30. And then after that, it declines. So we must start aging about them. I do want to do a small snippet. I think I have some time to talk about vaccine-associated adverse events. There is nothing that we do in life that doesn't have a possible side effect or possible adverse event. Most of us drive every day, and when we drive, we're at risk of an adverse event, a car accident. That's just one example. We try very hard to reduce those risks, hence we wear seatbelts. We now have airbags. But things do happen even with vaccines. So the vaccine adverse events reporting system is a very important system, and I want everyone to know about it. It's co-managed by the FDA and CDC. Anyone can report to VAERS, so it doesn't have to be a doctor. It can be a nurse, it can be a pharmacist, it can be the patient themselves or a family member. It can't tell us if the vaccine caused something, but it can give us an early warning signal, which is incredibly important. This is actually how we learned about the clotting disorder with the Johnson & Johnson vaccine in the US. It's incredibly helpful. This is an example of the form that can be filled out online. And I just want to reiterate anyone that can use it no matter what. So I think we now have time for questions. I can stop sharing.
Yes. I will pop my screen up here. Awesome. Wow. Thank you, Dr. Talbot, for that great presentation. Such wonderful information. And before we move into the questions, I'd like to just point out that there is a QR code that people can scan if they're able to. And then please put any questions you have into the chat. I don't see any right now, but we did have a couple come in. Oh, yep, we just had one come in actually. Can you repeat which vaccines are covered by Medicare Part B?
Absolutely. Flu, pneumococcus, and COVID. In some instances, hepatitis B is covered, but generally it is not.
All right, thank you for that. And while people are kind of thinking of their questions, I'll move to some that came in during registration. So how did the importance of the RSV vaccine for adults come about? This person just said, I always thought this illness was more specific to infants. Good question.
Yes. Yeah, it's a great question. So when we first started looking at RSV, it was definitely only seen in children. As time went on, we began to see more disease in older adults, and it's been known in the nursing home literature for a long time. It was rarely tested for in older adults, mainly because the antigen test didn't work. And cultures, this is the days before we had PCR, cultures didn't work because by the time they left the nursing home, the virus would die. So we had really little data on RSV until we started using PCR. And that's when we began to see a lot of disease that we didn't know about. So there's these two phases of life. This happens with flu, but particularly with RSV. When you're young, you have severe disease. As we age, it's kind of like the cold or allergies. A study was done where they looked at families and adults would complain about it was just allergies, and it turned out they had RSV because it's such mild disease. And then as we age, disease becomes severe again. It took years to develop an RSV vaccine that was safe. And when they did, we introduced it and realized almost no one knew that adults got RSV. So you're not the only one. And so now we kind of go back and we have to really educate people about RSV. The CDC website has those beautiful graphs about COVID, but you can also get graphs on influenza and RSV that you can play with. You can look at it by age or by place. And so you can actually look at the amount of disease that we see in older adults.
Okay, awesome. Thank you for that explanation. And then one other one that came in through registration was how to get a better handle on vaccine hesitancy.
I honestly don't know. That is not my field of study. But I greatly appreciate those that do this study. The best advice I have is those that are truly hesitant to be open and to answer questions. There are some that are not truly hesitant, but are definitely decided that all of them are bad. And I don't know that you can necessarily change that viewpoint. But I try to be very open to questions and to be very honest and very transparent. And I think one of the things I talked about being honest about what the vaccine prevents is critical, because I think if we say it prevents infection, you won't get infected at all. And then people get infected, they're less likely to trust us.
Yeah, that's a really good response. Thank you for that. And I really liked how you talked about, because I don't think everyone realizes that a vaccine doesn't necessarily prevent you from getting the illness at all, but it just, you know, decreases the complications. So I think that is just a good reminder. I oh, one more just came in. Does getting a vaccine over and over, like COVID, eventually cause a decreased response to the vaccine, especially in older adults?
Yeah, I love this question. And once again, I have a partial answer, mainly because this research hasn't been done extensively. We know some of this from influenza. Um, we do not continue necessarily to have a higher response to immunization, but we know you still are protected from disease. We also know that your first COVID that you were exposed to, you were imprinted with. So as you were exposed to different kinds of COVID, your body will go back and make antibodies to that original one. So they're not 100%. So when we vaccinate you over and over again, we may not be getting the response we want because you were imprinted with the first one. And we definitely see that with influenza. There was a time when H1 circulated. And that's most adults over 65. And so when they get H3, they get sicker because they were imprinted with H1N1. My generation was imprinted with H3N2 because that's what was circulating. So my generation got very sick when the pandemic and H1N1 hit. So there is a big impact on what your first exposure. Yeah, I would love to decrease the number of COVID vaccines that we give older adults, but we're still seeing so much disease and so many deaths. I think the benefit of multiple vaccinations for COVID is still important, is still overrides any risk of decreased response. And if COVID would just pick a season, maybe we wouldn't have to do it quite so often. Just pick a season.
Awesome. All right. Any other questions?
That was definitely a whirlwind. if someone sends you a question later, I'm happy to answer. Um, because that was really fast with a lot of data.
Yeah, that was. It was really just cool to see that data too. Um, all right. Another person. What a great presentation. I loved it. Thank you
Thank you.
for that. Um, okay, well, it looks like I don't see any more questions coming in, so um, all right. Well, thank you so much, Dr. Talbot, for delivering this just amazing presentation. And to all the attendees who could be here today, to stay connected with us, you can follow Healthy Nodoc on Facebook, Instagram, Twitter, and Foundation for Healthy North Dakota on LinkedIn. And also to join the coalition, you can visit the link to stay aware of future updates and future webinars as well. And then here is another opportunity to scan the QR code before it is sent out via email. And again, thanks to everyone, and I hope you have a wonderful holiday season.